Good evening and welcome to UT Southwestern's Science Cafe. My name is Charlondra Thompson and I am a member of the Public Affairs team at UT Southwestern. On behalf of my colleagues, Jeannie King and Joya Lane, as well as our guest speakers, Dr. Wanpen Vongpatanasin and Dr. Rong Zhang, thank you for joining us tonight. Science Cafes are online conversations where our speakers take you on deep dives into the science of healthcare. As an academic medical center, UT Southwestern brings research, health education, and patient care into one institution. And our research informs care advancements quickly, which is a benefit to our patients and community. This evening, we are discussing the link between hypertension and Alzheimer's with Dr. Wanpen Vongpatanasin and Dr. Rong Zhang. Dr. Vong and Dr. Zhang, thank you for joining us this evening. Welcome to Science Cafe. Dr. Vongpatanasin, the virtual podium is yours.
Thank you very much. I'll go ahead and share my slide. Thank you for the introduction and great to see everyone here who are interested in hypertension and Alzheimer's disease. Let's see, okay, I think that's the one. Let's see. I'm going to try to put it on presentation mode. Just a second. Okay, that looks okay. All right, good. So I guess I'm going to go ahead and start with the poll question. Joya, if you could launch one. So I'll ask if you recently get a new blood pressure monitor and you start to use them regularly, and on average, your blood pressure over the past 2 weeks is 117 or 82. Is that normal? So A, yes, I can't see what is in that because the poll is the same kind of move the poll. Because the top number is fine. B, no, because the bottom number, the diastolic blood pressure is too high. C, yes and no, is considered borderline. All right, poll is ended. Oh, I think it went too soon, the second slide. This is the second question, but the first question, let me go back to the first question if we can. Oh, keep going back. Okay, this one. So actually it's B, and I'll go why. It's correct that the top number is high, but I'm sorry, it's fine. But because of diastolic blood pressure is also considered high. So either or high, then it's considered to be abnormal. So by the current definition, if it's average over weeks, your diastolic blood pressure at home is great. It's 80 or greater is considered now to be abnormal. Let's do the second question. You can launch it, Joya. Right. So I'm going to read it. So this you got the blood pressure monitor and start checking it regularly. An average over the past 2 weeks is 132 over 65. Is that normal? A, yes, because of the diastolic blood pressure is fine. B, no, because of the systolic, the top number is high. C, yes or no, because it's borderline. All right, the poll is closed, right? Okay, great. Now everyone is up to speed. Everyone's learning so quickly. Yes, absolutely. This definitely now current definition if systolic, either is systolic or diastolic is high, is considered to be abnormal. So this is definitely abnormal. And actually, if anything, you can close. I guess I can close it. So the current definition now, based on the American College of Cardiology, American Heart Association in 2017, have provided a new threshold where we call high blood pressure. It's now stage 1 begin as starting from 130 to 139, or diastolic, the bottom number between 80 to 89. Stage 2 is 140, 190. So either or will be considered to be abnormal. And really normal blood pressure, although might seem low to a lot of people, it's considered to be less than 120, and that's diastolic blood pressure of less than 80. And why would they come with such a change? Based on that definition now, up to almost half of US population have 46% have high blood pressure. And if you look at the age group of 65 or above, 7 to 80% now have high blood pressure. So as we grow older, it's not the matter if we're going to have high blood pressure, it's a matter of when we're going to have high blood pressure. And why would the threshold was lower to a much lower range? It seems like it's getting lower and lower with every version. At least there's some science behind it that when we look at epidemiological studies that was done many years ago, you can see that there's a linear relationship of which the either systolic or diastolic blood pressure is related to heart disease risk or stroke mortality. And this is beginning from even much lower range, beginning from 115 or above. So it's not just one that every risk is fine until a certain point it becomes suddenly abnormal. It's the risk is progressively increased with increasing blood pressure. It's not a jump in mortality. But having said that, that's just an observational study. The guidelines still give a different opinion in terms of what is the blood pressure threshold. I told you that the ACCHA said 130, but the European Society of Hypertension, International Society of Hypertension said still go with 140 for older adults, 65 or above. The American College of Physicians, American Academy of Family Physicians actually still recommend 150 as a threshold for beginning blood pressure treatment in older adults. That's part of the uncertainty is coming from the data. The study that started some of this is the SPRINT trial that compared. It was done in adults 55 or above, but a quarter of them have age 75 or above, and they compare effects of lowering the systolic blood pressure to less than 120 millimeter mercury versus the less than 140 millimeter mercury at the time back then. That was done almost 7 years ago. The standard is less than 140, and they found that the intensive lowering of blood pressure result in significant improvement in cardiovascular outcome. They actually stopped the clinical trial early because of market benefit in intensive lowering. The hazard ratio 0.75, that means like 25% risk reduction. And that's not the only study, but when they gather all the data together over the years, this graph showed that among all the clinical trials, the lower separation between blood pressure between the treatment arm and the control arm, the greater reduction in major cardiovascular events, not just cardiovascular events. And actually more recently, this is a study done, was just published last year from China, that's compare effects of lowering blood pressure. This one, I think that they give a little bit more goal of similar to the ACCHA recommendation, the intensive between 110 to 129. I like that they give a lower end of blood pressure range, not just less than 120 or 130. They at least give some target range, and the standard is between 130 to 149. They actually find very similar result to the SPRINT. The STEP trial show hazard ratio in the intensive arm of 0.74, almost identical to SPRINT, meaning that the treatment intensive reduction in blood pressure reduced cardiovascular events by 25%, 25%. What about outcome on the brain? That is a little bit less well studied, but there's observational studies show that the more blood pressure that we have over the years, the more toll that we got on the brain. So this is epidemiological study from beginning from young early adults to midlife called Cardio. They start from in the community survey and follow them every year from the age of 18 to 30. And because they follow them every year, they check blood pressure every year, and they found that the higher cumulative blood pressure, one might ask, what does it mean? It's like, think about smoking. Instead of you ask people how much you smoke a day, you calculate the pack year over the lifetime, how much pack over years it's smoking, how much is that? It's very similar to this concept of cumulative blood pressure over the years. It just showed that the higher cumulative blood pressure, the lower, and then they did the cognitive test 30 years later, 25, 30 years later, to find that the higher cumulative blood pressure, the lower cognitive function at the follow-up. And they just recently published another result looking at not just cognitive function, but also gait speed. So among people who didn't have stroke, gait speed is one indicator for physical function. The higher the blood pressure from the midlife, the slower when we they walk when they become older. So that's not a good thing. And this is actually, I think, is also very interesting. The same phenomenon is observed in kids. This is done in Finland, where they look at cardiovascular risk factor from age 6 to 12, and they did follow up every year until 30 years later, they become adult. And they found that cumulative blood pressure, systolic blood pressure from the age of 6 to 12 years old seem to have an impact on cognitive function. They didn't do a standard cognitive test like older adults, but they have some learning tests for children, and they found that the higher cumulative blood pressure, the lower they didn't do so well in learning tests, and is almost associated with like a 6 to 8 years delay in cognitive development. So it really has some impact, even the younger children. And same thing for the serum cholesterol. The higher cumulative cholesterol, the lower they perform for the test. And this is just a summary showing the number of cardiovascular risk factor they have. From children, the more number of risk factor, including obesity and overweight, obesity, cholesterol, blood pressure, the lower they perform when they become a young adult. So one might ask, why would that be the case? So in general, at least in older adults, it was thought that as we grow older, our aorta, the artery that come out right from your heart, that connect your heart to the rest of your artery tree. It's not only just a pipe, it also have a function that act as an elastic tube. So when the heart pumps, the artery expand, and that's buffer the increase in blood pressure. And where the heart relax, then there's an elastic recoil that prevent the blood pressure to fall so excessively. Imagine if you have a steel pipe, then when the heart eject the blood pressure go way up, and when the heart stop ejecting the blood and relax, it just go plummet way down. So as the artery becomes stiffer with age, and some more so than others, the most common problem is only the systolic blood pressure is high. And that can do a lot of things to the brain. I'm not going to go into detail. Dr. Zhang is going to talk about that. It could cause a damage in blood-brain barrier. That might cause deposition of amyloid and many abnormal proteins in the brain. And it might cause some decreased ability for us to clear amyloid from the brain. And altogether, it might cause cognitive impairment or dementia. And actually, there's some study to suggest the SPRINT MIND is a subset of the SPRINT trial that actually had looked at the outcome on mild cognitive impairment in dementia. And they show that intensive lowering of blood pressure reduced the development of mild cognitive impairment in dementia by about 15%. So hazard ratio 0.85. And this is a combined meta-analysis that shows that when combined with all other studies that's done in the field, that show similar result, that the ratio, the risk reduction somewhere between 15 to 20% risk reduction. So now that I'm going to change gear a little bit, now my part is to talk about blood pressure and cumulative blood pressure. So I mean, we can't go to the clinic every day. So we have to, if we want to check the blood pressure more on a regular basis, how do we do that? So actually the guidelines now have tried to recommend doing the blood pressure out of the office, try to measure the blood pressure at home, or M3 blood pressure to help assist in diagnosis of high blood pressure, and also to see if you're there at the goal. And part of the reason that we encourage more patients to measure blood pressure at home is that when we have blood pressure measure in the office, sometimes we have what we call alerting reaction. This is a study where the patient were having a blood pressure monitor through the actual arterial line, and then when the doctor come in and start putting a cuff on the other arm and start doing manual measurement, the blood pressure actually increased from normal. That's called alerting reaction. This is known since the 80s. And when the subsequent studies show that if the doctor comes in and do that, it can cause alerting reaction up to about 15 millimeter mercury and lasting for more than an hour. The nurse can evoke reaction, but not as much, only 5 millimeter mercury lasting for 10-15 minutes. So I usually don't do blood pressure measurement myself. I feel like the doctor shouldn't be doing that. It should be the nurse or medical assistant, and they can get the patient more relaxed. If we're going to do that at home, one might ask what we're looking for. So the clinic blood pressure of 130 or 80 was usually translate into the same average number at home, 130 or 80. So and again, I've emphasized average, not just one reading. If we're looking at clinic 140 or 90, that's correlated with home blood pressure of 135 or 85. I wouldn't, this might be too complicated for general audience. So 130 or 80 is 130 or 80, 140 or 90 equals 135 or 85. Why might that be? There's so many studies where they measure blood pressure at home and in the clinic in the same person. And if that's how they come up with, if the clinic blood pressure is this, what's the home blood pressure? So I'm gonna do another, the last one for me. If you can launch the poll, yeah. So I'm gonna ask about what's true about home blood pressure monitor. 1A, the more expensive, the better quality. B, if FDA approved, it should be accurate. C, if all automatic monitors are inaccurate, so no point to do that at home. D, it should pass the validation test as recommended by validatebp.org. All right, well, everyone gets it correctly. I'm very pleased. I haven't even showed that slide yet. Thank you. You're absolutely right. It should pass the validation test as recommended by validatebp.org. Thank you. There's many blood pressure monitor being on the market on electronic. You can get it from electronic website, or you can go to the store to get it. Unfortunately, only a tiny fraction that have passed the validation test. Is a study from Australia, but in the US it's the same. They have looked at 278 models of upper arm device for home use. Only 18% passed the attempt to validate it in some way using a standard protocol compared to the wrist device with the cuff. That's only 8% that has done the validation test, and none of the wristband or wearable device with this had no cuff, just a shining object. Zero, because the reason zero, because none of them, there has not been a standard developed for validation of this wearable device. So if you like to find one, and luckily, the American Heart Association and American Medical Association partnered together and develop a process where the company can submit their device and have the panel of experts review it and see if it passed the protocol. And you can find home use or office use with the model number and the manufacturer number in there. Other important part of doing it at home is we have to make sure you apply accurate method. Make sure that it's the support the level of the heart. Don't just hold it up yourself. The cuff has to be on the back arm, and the no crossing the leg, no talking, no texting, and foot on the ground, back support. And other than doing it at home, that's another way to do it, which can be done in our clinics or in part of our many of studies we call 24-hour blood pressure monitor. It's can be inflated every 20 to 30 minutes during the day and the night. And the tubes can hide under the shirt. It's look like cooked to something like a pager here. This is the pattern of a 24-hour blood pressure in the normal 30-year-old subjects. And although the blood pressure is variable, the top number and bottom number that looked fine, it went down with sleep. But this is for the patient, it quite labile throughout the day and the night. It's give us the advantage of knowing all day and night. So I just want to give a plug for our study that I actually collaborate with Dr. Zhang here, and that we were trying to see if we control blood pressure using a 24-hour blood pressure as the target, rather than doing in the office, can we see if there's an improvement or difference in blood flow to the brain, as well as structure and as well as cognitive function. And anyone's interested, we're still looking for more hypertension. They have to all have high blood pressure without cardiovascular disease or stroke. And our research nurse, Danielle Pittman, if you're interested, feel free to reach out, and we have a QR code as well. So that's it for me. We got to take any question. I don't know, we do a question now or we do it later?
Thank you, Dr. Vong. We are going to switch to Dr. Zhang now, and then we will do Q&A at the end.
Thank you.
Thank you. Dr. Zhang?
Okay, I'm going to share screen. We are going to switch gear. Okay, we're going to talk about Alzheimer's disease. Question number 1, what is Alzheimer's disease? Good, we have the result, right? So 80% of people answered both A and B. That's a correct answer in my mind, but I will tell you this is more complicated. When we go on with the presentation, you will see this, okay. Let me do this. Okay, so Alzheimer's disease is named after a German doctor. His name called Alois Alzheimer's. Back in 1901, when Dr. Alois saw his patients, August Dieter. So this is really a very challenging situation because these patients constantly repeat herself saying something like, I have lost myself, so to say. So that's back to more than 100 years ago. Let's see what's the recording for Dr. Alzheimer's when they have a conversation with the patients, want the examination for the patients. So what is your name, Auguste? Family name, Auguste? What is your husband's name? She hesitated, finally answered, I believe Auguste. Your husband? Oh, my husband? How old are you? 51, that's correct, right? So where do you live? Oh, you have been to my place. Are you married? I'm so confused. So where are you right now? Here and everywhere. here and now, you must not thinking badly of me. So where are you at the moment? We will live there. Where's your bed? Where should it be? So you can appreciate it. Okay, this dementia is called memory loss, particularly with the language, with the memory challenging. This is a debilitating disease. It's a very bad disease, terrible disease. We all know this, right? So this is patient's only 51 years old when she see Dr. Louis Alzheimer's. So this has been challenging. Not only now, by that time, it's also very, very challenging disease. So after 5 years, Auguste died. So Dr. Alzheimer did an autopsy on her brain and found this called senile plaques and neurofibrillary tangles. So only over the last 20, 30 years, we know these senile plaques, amyloid protein clumps, they are accumulated in the brain. Also there, you can see this one here on this side A, this is amyloid protein accumulation in the brain. And neurons also die associated with something called neurofibrillary tangles. So this has been a feature or hallmark of Alzheimer's disease from its beginning. So what is the progress made over the last 100 years? Because during this time, we don't have a final diagnosis of Alzheimer's disease. Only after people died, you get their autopsy of their brain, you do this neuropathological research and have a final diagnosis called Alzheimer's disease with amyloid and tau accumulation in the brain, okay? So this has only happened over the last 10, 15 years. So now we can do neuroimaging. Basically what I'm talking here is PET amyloid imaging, tau imaging, and also with MRI. So with this cutting edge brain imaging technology, now we can look in the brain to see, there is an accumulation of amyloid and tau in the brain. So then, okay, with MRI, you also can see the neurodegeneration. Like on the bottom of this screen, you can see the brain atrophy compared with the normal people. You see the brain shrinkage in the brain, right? So based on these biomarkers, right now with the National Institute of Health, they developed something called NTM model here for Alzheimer's disease. So here's the things get a little bit complicated, okay? You listen carefully. So you see this, I highlight these two categories here. So Alzheimer's by definition right now is based on biological construct. What that means here, you see the A positive means you have amyloid in the brain. Tau positive, you also see the tau accumulation in the brain. So this N here means neurodegeneration. You don't have neurodegeneration. You either have brain atrophy, neurodegeneration. This here is negative, or it's positive. Doesn't matter, you have the brain neurodegeneration. So the current Alzheimer's disease diagnosis, gold standard is you do PET amyloid imaging, you find the positive amyloid and tau in the brain. So you said, okay, PET imaging is so expensive, right? So what happened to other biomarkers? So you also can do the lumbar puncture to get this cerebrospinal fluid. And the cerebrospinal fluid, also you can measure this biomarker called amyloid and tau. And more recently, over the last 2 or 3 years, there was a breakthrough. Right now, even there's a proposal, you can measure this amyloid and tau biomarker in the blood, but this is still under development. So with all this neuroimaging biomarker developed, so we feel right now we are facing a conundrum in Alzheimer's disease research. So what that conundrum is, the conundrum here is people with memory loss have challenging language problem, memory problem, behavior problem, they may have a negative amyloid and tau in the brain. Okay, so you remember the question, 80% said it's both, right? So then, okay, again, when the people have this positive amyloid and tau in the brain, they may not have memory problem. So right now we got challenging here. In the old days, when you do neuropathology, you see the brain amyloid and tau accumulation combined with our clinical diagnosis with memory challenging. You call that Alzheimer's disease, correct? Yes. But right now with the current definition, it's only with positive amyloid and tau in the brain they call Alzheimer's disease. So normal people, some 30% of people, they have amyloid and tau in the brain, but they may not develop dementia symptoms. Okay, keep that in mind. Okay, so that's the fundamental scientific development in the Alzheimer's disease research field. We have to deal with amyloid and tau in the brain. At least as current scientists believe that is the case. So here, okay, so the fundamental or the mainstream of the theory behind why there was amyloid and tau in the brain is something called amyloid cascade hypothesis. We're not going to all detail this biochemistry about what happened to the amyloid and tau in the brain. So basically, there's a genetic factor components. They can produce more amyloid in the brain. And this amyloid can trigger tau accumulation in the brain, eventually causing brain inflammation and also with oxidative injury, means a neuron injury, neuron dying. So then eventually leading to the dementia. That's have been a fundamental theory in the Alzheimer's disease. So over the last 20, 30 years, people have been working hard on this hypothesis, try to develop different medications, pharmaceuticals to deal with this amyloid and tau accumulation in the brain. How do they do this? So on the top here, that's the amyloid precursor protein, is a big protein. So in the brain, this protein will be cut into pieces through the different gamma secretase, beta secretase, different enzyme, and causing smaller peptide. So this smaller peptide called amyloid peptide, they can accumulate, clumping together, formulates plaques in the brain. So people have been working on trying to develop these enzymes to slow down the process production and also develop some small molecules to inhibit aggregation. And more recently, there's called A-beta immune therapy. You probably hear this name called anucanibab, last year approved by FDA. Try to remove these amyloid plaques in the brain. Given all these efforts, spending billions of dollars by pharmaceutical industry and research, and nowadays we don't have effective treatment with Alzheimer's disease. That's the current situation, okay? So why is this? Why we are not successful with Alzheimer's disease? So that's going to look into brain, okay? So this is a well-conducted study in the longitudinal follow-up study. I'm not going to the details of this pie chart. Just a pie chart of each of the kind of pieces of here is just different pathology in the brain. Let's see this, okay. So with a clinical diagnosis AD, when you look into this brain here, right? So with a clinical diagnosis AD, only 3% of people have pure AD, okay? That means they have a lot of pathology beyond A-beta and tau. Let's look into this normal people, okay? So normal people here, 8.3, about 80% of people, they don't have any symptoms of dementia when they die, they take off the brain. You find these people have amyloid and tau in the brain. So normal brain also have amyloid and tau. What's going on here, okay? So then you see that when you look in the brain, few people with they call this Alzheimer's disease, but actually these people don't have amyloid and tau in the brain, but only with 4.8 people, it's because of vascular contribute to their dementia symptoms, right? So with the normal people here, 28% of normal people, they have vascular damage in the brain, then they don't have symptoms. So things get complicated. Okay, we remember the first question I asked you guys. So this is the current research understanding. We're not successful with Alzheimer's disease treatment because Alzheimer's disease is a multiple pathology in the aging brain. Okay, we have to deal with different targets, not only amyloid and tau. So what is Alzheimer's disease? Let's learn something new. Alzheimer's disease is a major neurological disorder characterized by the abnormal accumulation of misfolded amyloid and tau in the brain. Yes, we're still talking about amyloid and tau in the brain. However, the etiology of Alzheimer's disease is not completely understood. It looks like a multifactorial disease and the multiple pathways that can contribute to the dementia symptoms. So mounting evidence indicate Alzheimer's disease is a multifactorial disease associated with both genetic and environment risk factors. So what is the genetic environment risk factors? Okay, so here's the summary. Last year, NIH have this summit called Alzheimer's Disease Summit. They summarize this. So you can see lifestyle factors, physical activity, diet, drugs, alcohol abuse, environment factors, education, head trauma, toxin, psychosocial factors, depression, anxiety, aging, genetic factors, apolipoprotein E, we're not going to discuss today, maybe another time. And Alzheimer's generally, female have a higher incidence compared with the male. And other medical risk, we are going to talk about. The first one here, hypertension. We dive into the hypertension to see why hypertension is such a risk factor for Alzheimer's disease. Then there was health disparities in the minority group. It seemed to be higher risk for the Alzheimer's disease. Okay, so bad protein in the brain, amyloid and tau are other proteins like alpha-synuclein and TDP-43, that's new funded protein, they all can contribute to Alzheimer's dementia symptoms. With a vascular, the stroke, people have a stroke, have a blood vessel disease, also contribute to dementia. Okay, so let's dive into this one. With a complicated disease like this, what we're going to do with this? What is the current funding suggest control cardiovascular factor potentially can slow down Alzheimer's disease? So this is a study done in England. So we're not going to details with this study. We just show with people did a study in the 1989 to 1984. This showed this bar with a risk of estimated population risk of people over 65, their risk for Alzheimer's disease. The same region with the same diagnosis approach. After almost 10 years later, what you see here is it's a 22% reduction in the general population of Alzheimer's disease. So newer cohort people have less incidence rate or prevalence of Alzheimer's disease. Why is this? So people have been thinking about this. So most likely because of cardiovascular risk reduction, people have right now we have a better way to treat cardiovascular disease. 3 landmarkers I like to show here. The first one in 1961, the Framingham study suggests high hypertension and also high cholesterol level contributed to cardiovascular disease. Then, okay, in the back in 1970s, so National High Blood Pressure Education Program start. People start paying attention to hypertension. Then we move on to the 1980s. Then we start control the cholesterol. All these factors potentially can contribute the risk reduction for the cardiovascular disease. They may be also contribute to the reduction rate of incidence of the Alzheimer's disease. Okay, so hypertension is bad, right? Hypertension is big blood vessels. They cause damage to the vessels here. They also cause this glymphatic. Dr. Wanpen mentioned about this clearance A beta in the brain potentially can be slowed down. Okay, how this system works? So generally with arterial pressure, you have these oscillations. They can be a driving force to get the cerebral flow going through the brain parenchyma, move this amyloid tau back to the veins and clear out. So how do we know this? Can we test this in humans? So this is a study we did many years, 20 years ago to show blood pressure, it's not constant, it's fluctuation always, right? Always have these different time scale fluctuations. So this one, also pressure can fluctuate, can transmit it into the brain. This is a transcranial Doppler. You put a Doppler signal here, you can see blood flow oscillation too. And we do see this blood pressure caused oscillation, blood flow in the brain, right? So these things we are thinking right now likely to be a driving force for this A beta clearance. So that's how they are linked with hypertension. They may modulate these oscillations. So like Dr. Wanpen showed you previously with this circadian or 24-hour blood pressure, when we do a 24-hour blood pressure recording, we found that people, they have dysregulated 24-hour blood pressure. They have higher amyloid accumulation in the brain when you do PET amyloid imaging, right? So also, we can right now with MR technology to really look into different regions for these oscillations in the brain. And we recently published one paper to show here, this is on this side here, this is amyloid accumulation in the brain. On the top here, you can see that's the different regions of the brain have different amplitude of oscillations, this oscillation I talk with you. And it seemed to be the oscillations was attenuated, the amplitude of this oscillation getting smaller, you get more amyloid in the brain. So these things, they are linked with the blood pressure treatment, linked with the vascular stiffness, linked with amyloid accumulation in the brain. Okay, so here you may ask, when we treat blood pressure, what happened to this amyloid accumulation in the brain? What happened to these oscillations? That's a new study we want to do with Dr. Wanpen together in the future. So I'll leave you guys with this, a sound mind in the sound body, to support a discussion this evening. Means we have to take care of our body or the cardiovascular system. Then potentially that would be a good way for us to maintain our brain health. I will stop here to answer questions. Thank you.
Thank you, Dr. Zhang and Dr. Vongpatanasin for your presentations. We are now going to jump right into the Q&A portion of this session. First, we will start with questions that were submitted ahead of time, and then I'll address some questions that are in the chat. Some people have direct messaged me, so if you have any questions, you can keep those coming. The first one was submitted ahead of time. It says, outside of prescription medications and a general healthy lifestyle, what has been proven to preserve cognitive abilities or even just delay memory loss?
So Dr. Wanpen, you want to take that answer?
Well, like I said, I think that at least observational studies said that the more cardiovascular risk factor, the fewer cardiovascular risk factor keep the cholesterol at optimum levels, keep the glucose in a normal range. I think that along with all this healthy lifestyle, pretty much whatever you do to maintain healthy cardiovascular fitness, I think the good news is that you don't have to do much more. But I think I agree that there are more research that we needed to learn if there's anything else that we can intervene on besides the medication.
Okay, I also want to add something. Okay, currently, there's a lot of clinical trials ongoing to try to understand lifestyle interventions on the brain health. Like Dr. Wanpen mentioned about the major ones, the cardiovascular risk reduction. We also conducted exercise study in people who have memory problems. With a short term, with a 1 year, we do see some benefit for the brain network function, but it's a small study. But we do clearly see with aerobic exercise training, they can improve brain perfusion, they can improve brain vascular function. We published that result last 2 years. If you're interested, you can contact us and we can provide the publication information to you. any other questions, interesting questions we can discuss? Please, please feel free to ask us. Also, you can turn on your microphone. We can just talk. Okay, I think this is a good opportunity for us to communicate, to reach out to you guys, and maybe we can working together in the future, and to help understand what is the Alzheimer's disease. How can we do the better work to prevent Alzheimer's disease? That's our goal, right? That's the scientist that we are. That's our passion. That's what we like to do.
Hi, Dr. Zhang. I don't know if you can hear me.
Yes.
Hi, my name is Pallavi. I'm one of the UD Southwestern radiology residents. I'm doing research on preclinical and prodromal stages of dementia.
Yeah.
I have a few specific questions. Have you seen any differential impact of race on systolic blood pressure and cognitive impairment?
Oh, yeah. I mentioned very, very briefly in my presentation. You know that, okay, generally in the African-American population, they have a higher blood pressure, and also their incidence rates is higher compared with white Asians. They have about double of the incidence rate of the Alzheimer's disease risk. And the Hispanic population, probably 1.5. That's based on observational study, and we'll continue working on to understand what is a biological reason behind this, or social economic reasons behind this health disparity. That's a very important question.
Thank you. I also want to know, have you, I know that you briefly mentioned that you were going, or you are studying the effect of blood pressure medications. I was interested to know that, are they, in your study population, do you have these earlier stages of dementia, like preclinical stages of dementia? And have you seen any impact of BP meds on these early stages, such that you would probably not want to have very low blood pressure ranges in older adults with early stages of dementia? Have you seen anything like that?
Okay. Again, you are asking these key questions. We try to address in our studies. Okay, the bottom line here, like Dr. Wanpen mentioned in her presentation, different organizations, they do have different guidelines regarding what is the best target for blood pressure control, particularly in the older population. And we hope to see more evidence, include our recent completed study I did together with Dr. Wanpen. We did a multi-center study, a national study. We're not only control the blood pressure, but we also using the statins to lower down the high cholesterol. So to answer your question directly, with the optimal target for blood pressure control for brain health, in the general population with the optimal target, we don't know yet for brain. Okay, we know clear for cardiovascular risk reduction. We don't know that magic target for the brain yet. Okay, that's the first question. And second question, secondly, to address your question regarding prodromal Alzheimer's disease, as called generally, the name called mild cognitive impairment, means these people still functioning well, but they have memory complaints, and with objective assessment of neurocognitive function, they show memory problems called amnestic MCI. So we did a study in the MCI with aerobic exercise training. I mentioned briefly, we do see the improved vascular function in these people. Regarding the recently completed trial, I believe in our study, because we're targeting a high-risk population, means they have a family history of dementia, or they have subjective memory complaints. So these people do have concerns about their memory over the last couple of years. They see the decline. As I assume, I don't have direct assessment for maybe when we look back retrospectively, I can see how many people in the mild cognitive impairment stage, how that people will respond to the blood pressure treatment. We have the data. If you're interested, you're welcome to working with us to look in this data.
Thank you so much, Dr. Zhang.
You're welcome.
Very helpful.
We'll move on to a question from the chat. This is from John Sapo. Is there a group which shows very low Alzheimer's disease? And if there is, which one, which group, and what are the contributions to the low Alzheimer's disease?
Wanpen, you want me to address this question?
Yeah, that would be better. I'm not neurologist.
Okay.
Not neurologist.
I probably can say a few words on this. It's a very, very interesting question. Okay, so that's what we try to understand. They call it resilience. Okay, so basically, why some people develop Alzheimer's, some people, if you remember my presentation, people have this amyloid and tau in the brain. Even the late 90s, they don't have any symptoms until they die. Okay, a lot of amyloid and tau, we call it Alzheimer's disease in the brain. They don't develop clinical symptoms. So what's going on with these people? People have tried to understand what's the protective factors, not only the risk factor, but what's the protective factors. Number one, potentially there are some genetic, recently studies suggest there are some genetic factors, they are protective, like ApoE2. There's also different genetic factors potentially can protect your brain, even you have this bad amyloid and tau in the brain. And secondly, to my knowledge and linked with the presentation today, people have a better cardiovascular health. That's called American Heart, called Life 7. You have well-controlled blood pressure, you eat well, good education. There are 7 factors. If you are meet with that 7 factors, currently evidence suggests your brain health is better compared with some people, they have risk factors. Called Life 7. If you can Google that Life 7, basically it's blood pressure control, lipid control, exercise, no smoking. What is good for your heart is good for your brain. Simple. Oh, I don't want to say simple. Okay, it's a complicated disease we're still working on.
Thank you, Dr.
But I
Zhang.
don't want to convey this knowledge to you, to the person listening to this talk. It's just do the best to your body. It will be transferred into your brain health.
Dr. Zhang, I have a question about statins. Can you tell me how you feel as far as, do you think that statins can make a difference as far as brain health and lowering the cholesterol?
Okay, this is another debated topic. Okay, I don't know, I haven't checked their label recently with the FDA approved statin use. They do have a warning signal there called statin may cause memory problems, right?
Yes.
That being a concern with a lot of people. However, if you look in these large observational studies, at least, again, whenever you look in the publications medium, take a grain of salt, okay? Since this disease is complicated, okay, with a large observational study, at least with the current evidence, they didn't show bad effect of the statins on the memory. So the early on with that memory warning signal is during the phase 4, there are some report to FDA. Some people develop memory problems, but not likely to be causal. So I want to give you this information here. It's like this, okay? Statins, great evidence suggests reduce your cardiovascular risk factors, at least to protect your cardiovascular health.
Right.
Whether statins have a significant impact on the brain, we don't know yet. I just mentioned in our current finished trial, we lowered lower density lipoprotein by 30% to 40%. We'll see what's the impact on the brain. Stay tuned, look into our publication maybe later this year. We're working very hard to get the result published.
Okay, thank you very much.
You're welcome.
I really would, because I've been told that I need to be on statins, but I've also read what you were talking about, that there's a lot of reports that, or not a lot, but there are reports that it does, could possibly signal memory issues and problems.
There's no clinical trial, to my knowledge, right now regarding the statins control on the lower down, taking the statins, particularly with high potent statins, what are the impact on the brain function? You may want to be interested, recently NIH just funded another multi-center trial just looking into your question specifically, they're going to spending a lot of money, probably with 9,000 of people, if I remember correctly. They were addressing that question, particularly your question.
Mm-hmm. Okay, thank you very much.
You're welcome.
There's
question,
someone
Tom.
raised a hand. I think.
Yes, we have a hand up from Ron Shashankly. Ron, would you like to unmute?
Yes, thank you. I actually had a general question, two-part question. I don't have a research background in this. I work at CRI with the mitochondrial disease research, but I'm curious on the impact of perhaps on stress, long-term stress and acute stress on incidences of AD, and then if there have been any comparative studies which look at perhaps incidence of the disease in people who live high stress lifestyles, like what we do here in the US. We have a lot of risk factor that way, but also in terms of like involuntary stress, like famine, war zones, things like that. If there is any link between stress and AD incidence, if we see a higher or lower or no connection at all.
I think epidemiological study, of course, showed some socioeconomic background might play a role. But talk about stress, I think it's a little bit. It could be a lot of things. So I would say that it's not just stress. I think it's more the way we handle it. I think people who just are not able to cope and maintain healthy lifestyle. Because when you give challenge to someone, one can find a way around it and tackle the challenge where others would give up or try to do easier things. So I think it's not easy to coin what is really stress to someone. I would say that yes, although while that might be true, but I think that the research consistently show that healthy behavior, whether you have stress or not, is associated with maintaining or better cognitive function later in life. So I think that's the good news, including people with even a genetic background. So even among people who had a carrier for the gene that might make them more susceptible to AD, but if they can maintain healthy lifestyle the best they can, I think we can delay development of AD or Alzheimer's disease as well as cardiovascular disease. There are many genes that are involved in development of early atherosclerosis, but that's one thing. But you can live healthy, that can delay development of heart disease, and we'll have to see what else can we do on Alzheimer's disease.
May I ask one follow-up to that?
Sure.
In terms of the trends and the patterns in diagnoses, have we noticed any differences in like the age groups that are being diagnosed? Is it trending younger, lower, or is it just maintaining the same strictly due to access to testing? Or are there expectations that the age of diagnosis will drop?
I've looked at Rong. I know this a lot better than I do. I just visit the Alzheimer's disease website to look at the latest stat. It looks like it's still about the same compared to a few years ago. That it's age dependent. Of course, it's very rare before 60, and after the 80 years old, it's a third of the population after age 80 will have Alzheimer's disease, and that seems to be about the same. And women have higher risk than men. That seems to be about the same. And but it could be. It's a bit hard to do a stat in pandemic time, particularly in the past 2 years. So I don't know whether that's accurate. But that's what the Alzheimer's Disease Organization data show.
Thank you so much, Dr. Vong and Dr. Zhang, for your presentations. My internet dropped out, so I had to miss some of the Q&A, but that which I heard was very enlightening. So thank you both for that. Thank you to Charlie for helping run tonight's event, and to Katie and Windsor and team for helping Dr. Zhang and Dr. Vong and getting the word out on this presentation. We hope you'll join us next month for our final Science Cafe before we take a break for the summer. It's going to be on skin cancer, and I will post the link in the chat. On behalf of our faculty and our speakers and the whole team, we just want to close out this evening and wish you good health, wellness, and a good night. Thank you, and we are adjourned. And I'm going to add this link in the chat for our next session. Thank you all.
Thank you all.